Greetings from Indian Medical Association. I am Dr. K.K. Agarwal, Honorary Secretary General IMA and President Heart Care Foundation of India. Welcome to our weekly show, the weekly webcast, which is being hosted by IMATV, our digital partner, our webcast partner, and Librate, our digital partner. A part of it is also open to the public through Heart Care Foundation of India. And every week me and my colleague, Dr. V.K. Monga, we interact with an expert. And the expert today is Dr. O.P. Yadva, a close friend, a cardiothoracic surgeon, and who has established an institute over a period of time. I recall when long time back, it was difficult to have even think about opening a isolated standalone cardiac center in a place in South Delhi. And he has done that. Congratulations for that.
Thank you.
And he is also, we will also talk to him later on about his Almoda project, which is very dear to him because whenever he disappears from Delhi, you can find him in Almoda. And what is that? We will talk about it at the end of the show. At the moment, what we are talking about is being a cardiothoracic surgeon. We know that we are none second to best in the world. We don't have to go to US, UK or any other place to go for a cardiac surgery. Now cardiac surgery has become something like a cesarean or a cholecystectomy. It has the same mortality as that of any general surgery unless you are a high risk, unless you end up into a cardiac damage and then you go for the surgery. Whenever we do such types of workshops, we talk about when to do surgery. The first portion we will do when not to do surgery. That will be our focus, when not to do surgery. So we'll focus on coronary artery disease, we'll focus on congenital heart disease, we'll focus on rheumatic heart disease, when not to do surgery. Let's say coronary artery disease.
Well, in coronary artery disease, when the amount of muscle in the heart which is in jeopardy, that is small, then surgery is usually not indicated. We generally go by the notion, if it is a triple vessel disease or all three arteries are blocked, then we should go for surgery. And if it is a single vessel disease, we can manage medically or with an angioplasty. But we don't look at where the disease is located. If that disease is located in the beginning of the artery, then even a single vessel disease may have a huge amount of myocardium. But if 2 or 3 side branches have already taken off before the block, and if in the distal portion artery is blocked, and be it triple vessel or double vessel, it doesn't call for intervention. So it is extremely important today that we don't talk of vessel disease in qualitative term, but also in quantitative term as to how much is the muscle. That is important.
There was a time we used to talk about meds in treatment.
Yeah.
We used to say if a person has 3 minutes or 3 minutes of exercise, then he is at risk. Then we used to say 3 to 6 minutes, 6 to 9 minutes, more than 9 minutes. If it is more than 9 minutes, we used to say mildly positive. You may not even go for a coronary angiography.
Sure.
Today we may not believe, but that's how what it used to be. From 6 to 9 minutes, they say the medical treatment is usually sufficient. And 0 to 3 minutes is your chances that you will end up into surgery. And 3 to 6 minutes, the chances are that you will go for an intervention, maybe a stenting or maybe a treadmill. Now these used to be the rough criteria.
Sure.
Are they still valid?
Well, they are valid. The notion is valid, though we do not. Now this has been refined in terms of a myocardial perfusion index or a myocardial perfusion score. But the concept remains the same, whether a small amount of muscle is in jeopardy or a huge amount of muscle. So I would say the concepts are valid, but how they are evaluated, the technology is evolving, and I'm sure there will be time when
suppose I get a person who says, I can walk 2 kilometers,
yeah,
absolutely asymptomatic. He says, I can climb 2 flights of stairs. I'm asymptomatic. I live with my partner, I do a bed exercise with my partner, and I'm not symptomatic with that. He comes for a treadmill, we do a treadmill,
yeah,
and treadmill is positive at 10th minute, mild disease.
yes.
Geography in this patient.
Not, I think it should be avoided. That's where we in medicine have gone wrong. And that's why we have lost our stature in the society, that we have given entrepreneurial and commercial flair to medicine. it is very well established today that a stable coronary artery disease does as well with intervention as with medical therapy. So, in these patients who have got a stable coronary artery disease, we do consider other factors like what is the age of the person, what is his economic status, what are our requirements of job. If he's a structural engineer, then the same description you gave me, I might consider him for an angiography. And if he's a panwala who is sitting down and doing all his activities sitting in one place, he may not qualify for angiography. So all these ancillary factors are built in into a decision making, but your point, stable coronary artery disease should not be intervened. I think today it has been proven proof positive.
Unless he is positive in the first 3 minutes.
If he is positive in the first
Even
3
if-
minutes,
even if he is symptomatic.
yes, then you will do an angiography.
To find out.
And if he has got certain subset of clinical lesions we associate with high mortality and long-term consequences like left main stenosis, proximal LED lesion, or if he has got severe LV dysfunction, where we would advocate some kind of intervention. Even after angiography, if you have triple vessel disease but stable and the amount of myocardium in jeopardy is not huge, I think the literature today teaches medical treatment.
Another simple thing which is how, if I do a bypass today, most of the people are doing a arterial switch only one, that is Lima. Most.
Well, okay.
You may be doing
Okay,
exceptionally.
yeah.
But as a whole, if you see in the country,
Yeah,
most of them will be using the venous graft, except
Yes.
for the LAD,
yes.
or except for the Lima, which
Okay.
will use it. Normally, after a bypass, I'm not talking about your center. If I take, how many people are getting operated in India every year?
Well, total we say about 250,000,
2.5 lakhs.
2.5 lakhs cardiac surgeries, out of which about 1.8 are coronaries.
Okay, around 2 lakhs, let's say.
Let's say.
So 2 lakh people are undergoing bypass surgery every year.
Yes.
What is the average life of a bypass? See, again, I'm not talking about best of the centers.
Well, if you are talking of all vein revascularization, I would say an average life of 10 years.
10 years.
If you add a Lima to the LAD, the life prolongs and goes about 12 to.
Okay, 12 will be
whatever.
only for that artery, not of the venous graft.
Well, not of the venous graft.
I'm not talking about life, death, I'm talking about symptomatic.
Well, that's what I'm coming to. In fact, the best parameter in this situation is what is the chances of coming back with a disease which needs a re-intervention.
No.
So if a Lima to LAD is
I'm
functional.
before that, I'm saying symptomatic.
Okay, 10 to 15
10
years.
years, that's it. So therefore, if a person comes at the age of 40, he is asymptomatic,
Yes,
TB positive at 9.5 to 10 minutes.
sure.
Okay. Why we get a bad name is because you're sitting on the balcony, you need a surgery immediately. That's a usual reaction. Again,
That's
I'm
an
not
exaggeration of a
again,
doctor.
Again, I'm not talking about best of the centers.
Yeah,
So this is what the perception is with that.
yeah.
Now, if a person comes at the age of 40, I always calculate the family age. I says mother age, father age, nana, nani, dada, dadi divided by 6.
Perfect.
That's how I calculate.
That has a lot of scientific logic.
So I said,
Yes.
what's your family life?
Yes.
They says our family life is 80.
Yeah.
I said you are now 40. I need to give you 40 years. Okay.
Yes.
So if I can postpone your first intervention by 10 years,
Yeah.
like my first approach is, can I postpone your first intervention by 10 years?
Yeah.
Scientifically, evidence-based, if it is possible, we'll do it.
Yeah.
Suppose I get you 10 years with the lifestyle management alone. Okay? Another 10 years, then my second will be, can I get a stenting? There's an indication between stenting and bypass. So I'll say, if stenting can be done, let's go for that, unless there is an absolute indication for bypass.
Yeah.
Stenting will give me another, say, 1 stenting, 2 stenting, repeat stenting, suppose it gives me another 10 years. Okay, so I get 10 plus 10, 20. And then I say, okay, now you go for a bypass. Okay, and then bypass would last for 10 years. Redo bypass, you still have an option. So I give you absolutely 40 years of planning.
Well, it sounds very beautiful if only it was the planning of a banking system. Let me tell you, human life doesn't work according to this plan.
No. I'm saying is
Let us not forget that the first restenosis that you're going to have of a stent.
that is, can into scientifically evidence-based. That means he is a chronic, stable disease, medical treatment is justified, so let me carry on. Can I continue it for 10 years? So I forcibly tell him, change your lifestyle, take out smoking, do this, do this, do this, try to live. Otherwise what will happen is, he will not change. If I don't tell him that I'm planning for 10 years intervention free, then only he will listen to me. If I can, then I go back, there is an option between stenting and surgery. If both the options are available, given by you people, that you can go for this, then I will tell him choose
one
stenting.
Okay.
Fair.
Fair.
This is what I'm, then choose stenting. He is not.
If both options are equal,
yes,
then stenting is anyway preferable.
We are not talking anywhere. If at the age of 40, if there is an absolute indication for a bypass surgery, he has to go.
No discordant
We are not
debate on
talking
that.
about that. So
There's
what
no
happens is,
discordant.
I'm only telling you, this is the approach which I follow,
Yeah.
and which I feel it's very easy to convince the person when I give this approach. I said when you go to a doctor, you first thing is, don't ask them bypass हो सकता है कि नहीं हो सकता. Don't ask them angioplasty हो सकती है कि नहीं हो सकती. Answer will be yes. It can be done. You always ask is, can I postpone my intervention for 10 years? If not, go for it. If yes, try for it.
See, whenever a person asks this question, then don't forget that today is a day of consumerism and medical legal litigation. No doctor can ever give a categorical answer, yes or no. All he can quote a figure that, look, even after an intervention, coronary events do take place, and they will take place at the same rate at which with the medical treatment will take place.
That is a different issue. We are talking about is when you are giving a person an option, that you have an option for medical treatment, you have an option for stenting. I would say go for medical. When we are giving an option.
Everyone will say, even the doctors would
The
say.
second thing which is very common for me, which I normally do. Most of the time people say that your surgery is imminent. You have to get it done today. You have to get it done today. And the person says, I don't have money, I need 2 months to arrange. This is okay, time given for after 2 months. So where was the emergency?
No, but this is not
No,
a
no.
In
No,
fact,
I'm only,
no, what is the
I'm not-
question?
My question is,
Yeah.
I'm only trying to say is, I'm only giving some methodologies for counseling the persons, which I follow. I'm only trying to see whether they are correct or not. This is how I follow is that if there is an option given by, I don't do angioplasty, I don't do surgery. If a person comes to me that somebody has told me these are the two options, what do I choose? Angioplasty or surgery? I say go for angioplasty.
See, when you say that it is an emergency, suppose the person has got a left main
There is an
stenosis.
issue.
No, it's not a listen, give a chance to
left
explain.
main.
Even if it is a left main, and if a person says, and is a genuine indication of emergency surgery, he says, I have no money. Now we are sitting in a private sector. It's very easy to say that, look, we must honor our commitment to society. But where do we get the money to run the hospital? Well, KK Agarwal, if you can send me the money today, let me tell you, I'm ready to do 10 a day tomorrow onwards.
No.
And I have no shortage of patients
I
from
said-
So many
anywhere.
in the pipeline, you know.
So there is the problem
I
that,
said if you have-
but there is an emergency, and yet the patient goes home. And whenever we say emergency, we are not saying 0 or 100. Emergency doesn't mean that 100% of patients, but even if 10% of patients may have a cardiac arrest with the disease process, we say it's an emergency because we don't know who those 10 out of 100 are, and that each life is absolutely of incalculable benefit to that family. So I
Okay,
think that is a
let's come
misconstruction
back to
of.
But then OP, this controversy has been there always and will remain, I think.
No, but because we have in our own society, we
There is a
doctors don't
renowned
agree
cardiologist-
that
there is
we
a
have
renowned
thugs
cardiologist-
amongst us.
Let's go.
We all know we have cheats and thugs amongst us.
Yes.
And they are doing these kind of practices.
Mm.
So this is the way it is, but there are
But on
certain.
another extreme, there is a cardiologist, very renowned cardiologist in Delhi who says, I never advised of something in my life.
That is another extreme. Huh?
Yeah.
That is also good.
And let me tell you, if someone is doing all venous revascularization or using a lima, these are officially written on guidelines which are coming that you may be taken to the court of law if you do not use 2 or more arterial grafts. There has to be explanation, but these are not being. But a lot of peer-reviewed articles have spoken that today the patients must ask the doctor, doctor, what grafts are you going to give me? If you are not giving me arterial grafts, please tell me why.
Sure.
And today at National Heart Institute, every single patient by default will get total arterial left heart revascularization. Only for the right coronary artery, if it individual is more than 60, will he get a vein to the right? Otherwise, to the right also, he will get an arterial graft. So it is because of the ignorance of the
No,
society
I will go
that
other way
people are
around.
exploiting.
I will go other way around because they are different rules. We don't require CS. If you are sure about this, let us call 5 people who agree on this. I will immediately create a IMA guideline, put it on the website.
Please
Absolutely.
call and let's discuss that. Isn't
Absolutely.
there only those cases where there is a problem with bilateral IMAs, very
Different
obese
issues.
chest, insulin dependent.
So one
and-
message we have gone through, which is very important for our IMA viewers, that we all are practicing. People come to us. I'll tell you that there was a case which came in Delhi Medical Council from one of the major hospitals in the city, where the patient complained that a stent was put on me and I was not given the choice. I was not told what was the drug use, which was the stent, what was the size. He said I should have been told everything about the stent, and the decision taken by the court was that it is a duty of the doctor to explain everything. Informed consent includes everything. And today what Dr. O.P. Yadav has said is further, he said it is under the informed consent, it is your duty to explain to the person when you are doing a bypass, what do you mean by bypass, why venous, why arterial, why not total arterial. So everything you have to answer the person. You can't say only bypass has been done. So that's an important issue, and we will try to take it up with the as an IMA guideline to see regarding the same thing. Now, in which situations if you have a left main, that surgery is not required?
Left main only situation will be, I suppose, if the person has terminally illness which is of terminal nature, advanced malignancy, and he's asymptomatic. So then you would say that, look, you've got 6 months to live, so no point doing that. Or if he has got a left main lesion which is amenable to angioplasty, for example, it has been adequately shown that left main bifurcation lesions are an absolute indications for surgery. But left main ostial and mid-stem lesions, they do as well with angioplasty as with surgery. So if someone has got just isolated ostial or mid-stem lesion, I think angioplasty is a very good option and it can be given to the patient. And in such situations, surgery should not be opted.
Suppose if a person comes with a left main and he insists, I want a medical treatment.
Yeah.
Insists.
Yeah.
What do?
Well, you will have to give him medical treatment, then you explain him, look, these are not our recommendations. Explain him in a cajoling fashion that these are the statistics of medical management, and should he choose, he has every right to choose. You can't do anything, then you have to accept it. Get it documented that you have explained everything to the patient, and yet, knowing fully well the risks involved with medical treatment, he wants medical treatment.
Okay, quickly.
And then give advanced
when not to
treatment.
operate a valvular heart disease?
Valvular heart disease is one most situation, asymptomatic patient with good left ventricular function is left alone. Though there is some recent guidelines, recent evidence, and it has been included in the AHA-ACC guidelines, that an asymptomatic mitral regurgitation, if it can be operated with 99% valve repair statistics with under 1% mortality, in fact they have given these figures, then an asymptomatic mitral regurgitation can be operated. Severe. But otherwise, asymptomatic valvular lesions with normal LV function should be usually left alone and followed serially with echocardiography. Number 2, end-stage valvular heart disease. Some of these valvular heart disease with ejection fraction of 10%, huge hearts, wall-to-wall, and they have got mitral regurgitation. By correcting the mitral regurgitation, we make the patients worse rather than improve. So one should make out that there is sufficient myocardial reserve before you operate on an end-stage disease. So these are in generic terms where you should not operate.
Congenital heart.
Congenital heart, again, if the pulmonary arterial hypertension has crossed suprasystemic levels, then it should not be operated. If a person's, the doctor who's doing that surgery in his own repertoire doesn't handle that age of the patient, then he should not operate that patient but refer, for example, we say tetralogy should be operated when he is 10 kg weight. Now this is entirely based on the fact that we are not capable of or not fully trained to operate on a 2 months old child. Otherwise, if you have got the best of facilities, the very diagnosis of tetralogy at 1 month and neonatal, you will go for a repair. So, if a surgeon, and there is nothing wrong, he should not feel, everyone doesn't have the same repertoire. I don't have the same repertoire in coronaries, in congenital as I have in coronaries. So, they should communicate and send him to that center. Otherwise, and if he has got other anomalies, for example, if he has got severe mental retardation, now you can challenge me on that who are you to take a decision. I would not like to correct a congenital anomaly of a serious nature in a person with severe mental retardation, because I'm making him a burden on his own self, on his own family, and on society. So I think we will leave those patients with a heavy heart for the nature to take its own course. So if a person has got severe mental retardation with Downs, have got severe suprasystemic pulmonary arterial pressures, or it doesn't come under your purview of age, these cases should be left alone.
The new law has come, 2014 Organ Transplant Act, and there are some changes. And one of the biggest changes that it is mandatory to request the relations and the people who are legal here of the body
To donate.
to request. It's not mandatory to donate, it's mandatory to request the relations. Are you opting for donation? Therefore, a transplant coordinator has to be there in every hospital, and they have to give an option to the people. And now we are seeing every day. Even today there is a news that from Ahmedabad to this, they covered the heart in 40 minutes. Now we are getting almost like the heart transplant is taking place. The number of donors will increase as the request goes throughout the country. IMA is taking now a campaign that every member should know that their duty is that as a GP, if their family member, not their patient dies, they also need to explain why not donate, any brain death, why not donate. So sooner or later, heart transplant is going to become a reality. When I say the reality means everybody, every center who is doing a bypass should also have a facility for a cardiac transplant. How difficult it is? Why still it is handful of? Is it technology? Is it?
Well, no. I mean, it's a common thing that heart transplant is probably any day more easier an operation than a valve or a coronary.
Are you sure?
Very sure. Transplant technically is just anastomosing 4 major arteries, which each one of us must have done 10,000 times. Aortic anastomosis, superior vena cava, which is a 1.5 centimeter anastomosis, inferior vena caval anastomosis, and the LA anastomosis. There is no 5th step in the heart transplant.
And the previous heart stays.
No, previous heart is explanted always.
Okay.
Today, those were the days when there was orthotopic and heterotopic transplantation. The current way of doing the transplantation is very standard, almost 100% of the centers world over today. The previous heart is explanted, leaving a cuff of the SVC, leaving a cuff of the IVC, aorta, and all the 4 pulmonary veins with the surrounding left atrium. All you have to do is stitch the left atrium to left atrium and the 3 great blood vessels. Rest the heart is the donated heart, complete, LA, LV, RA, they are not touched or anything. So technically everyone knows that is the simplest or simple operation. The problem arises, one is in follow-up, how to diagnose rejection. So you need to have proper pathologists and regular endomyocardial biopsies. You need to have complete setup for sustaining these patients on left ventricular assist devices, because when the patient needs a heart transplant, your heart is not available straight away. These patients usually would present an end-stage heart failure collapse where they are put on LVAD. So the cost of the LVAD, and because the donor organs were available once in a year in most centers, so no one was ready to invest in these. And the cost of follow-up immunotherapy is so high that those are become a factor. But as far as technique of implanting a heart, I think that is a very basic technique which every cardiac surgeon today can implant it. So there has nothing to do with the technology.
So we do feel that I don't know, maybe in our time or maybe our children's time, it is going to, that every city will have a facility for a cardiac transplant. And maybe in 4 places or 5 places in different places, there will be centers for follow-up.
Well, I think
Pooled-
before
pooled-
that,
Pooled centers for follow-up.
we are talking of, kind of predicting the future or looking into the crystal ball gazing. Now, I think before that happens, the genetic forms of treatment, artificial heart, which is getting better and better today, we are now talking of more than, 600 days on artificial hearts. Those are going to evolve so much that you will have a heart available off the shelf, that you don't have to worry about the human heart.
What about the stem cell which we were talking about?
The stem cells is one is gene therapy, that you prevent the attack from occurring. You do genetic manipulation before a heart attack occurs. So with an epidemic which is getting bad 5 to 10 years, and thereafter you will find that the heart failure numbers will come down. When these forms of treatment will come up, these numbers will come down. If you look at valvular heart surgery, they've gone down tremendously overseas. You remember peptic ulcer? We found an answer. Now today there is no peptic ulcer. I learnt my surgery with truncal vagotomy and gastrojejunostomy. We used to do every theatre 1 or 2. So that way, all these kind of surgeries we are talking of, and I won't be surprised if in my lifetime, and I wish I live long enough, coronary artery bypass surgery and PCI, people will laugh that, look, these kind of operations also you are doing. They are most unphysiological surgeries and they're not going to last our lifetime. Before that, there will be a better form of option. And I put my monies on artificial heart.
Small GP or a small nursing home owner,
Sir,
a patient comes to his OPD or the casualty with symptoms of acute infarct.
sir,
ECG is done there and he is diagnosed. Around 15-20 years back, we will put him in our small ICU, give him all the lyses and everything there itself, and the patient will go home and then after follow-up we'll do whatever. But nowadays the tendency is for sending him to a health center for primary angiography, angioplasty and whatever is required there. So what is the difference between the results of the two, that time and now? And whether, it is legally or illegally, whatever it is, correct to treat a patient in your hospital in a small setup or not? That is a big question.
well, the first question is easily answered. If you look at when I was a student, masterly inactivity was the form of treatment of MI, and we used it at that. And the mortality those days of an acute myocardial infarction, the world over was in the range, I'm not talking of us, world over, was in the range of 20-22%. Today, if you do a primary PCI, we are talking of mortality of 4 to 6% if the patient presents to the hospital within the first 6 hours. So, is this form of treatment effective or is it a hoax? The answer is clearly pharmaco-invasive therapy is effective and it should be practiced in every single patient, at least in our current state of knowledge. Pharmaco-invasive means at the first point of contact is given thrombolysis and shifted straight to a higher center where facilities for angioplasty are available.
So
You should
both
not-
the things should be done.
It should be done both. Now, suppose you are in a center, your center very close, just 10 kilometers, and you think you can transfer the patient within 1 hour to higher center, then don't give thrombolysis, straight away transfer the patient, inform the other center that I am sending the patient, so they are ready, cath lab is commissioned, team is present, and door to balloon time is 5 minutes, 7 minutes, that's what they are talking. Door means emergency door of the hospital to the time that a angioplasty balloon has been inflated, truly can be 5 minutes, because once the patient comes, they take straight to the cath lab. The puncture and negotiating a guide wire is under 1 minute in any average center. The time is in the decision making. The time is on the road. So if you do not delay,
Not only on the road, but once you go in a hospital, they go do angiography, then they talk to the relatives, whether one stent is required, 2 are required, they'll think about it, they'll talk to their friends, and then it will be.
well, that is something peculiar to this country, but
Yeah.
otherwise if you have a faith in the system in the Western world, so that is the ideal situation. But if you cannot transfer the patient to a reliable center in a reliable time, suppose patient is present in Roorkee, and they cannot send me within 1 hour, they know that, or they have ordered for it air charter, but it may or may not arrive, then thrombolysis should be given immediately. But after giving thrombolysis shift, the patient do not retain.
Let me explain that. Here comes economics also.
Yes.
Most of the people feel that if I send the patient, I send the patient, if I keep the patient in my hospital for 7 days and then send for a angiography, some will die, mortality is higher, rest of them they will recover. This is, I made my money of 7 days, 6 days, or 5 days. Okay, I'm losing that money. But they don't recall that pharmacoinvasive therapy, giving thrombolysis, is a procedure. It's not giving an antibiotic. It's a procedure which is chargeable. So you can still recover your money. You can put down, then you're giving an injection of say 40,000 rupees. Thrombolysis charges is 20,000 for people who can afford. You have still recovered your money. Send the patient back to the other people. So that should not be a criteria that I'm losing money, therefore I will not sell. Thrombolysis is a money in angioplasty and surgery, but those hospitals who are only doing invasive therapy, they are only doing the pharmacological part. They will bill enough adequately so that they get compensated. There's nothing wrong in it. There's nothing unethical
Those
about
charges
it.
are there.
There is nothing unethical about it. You're not going to give an injection of 40,000 rupees for free. You are standing there. You are supposed to be standing there. You're supposed to have a defib with you ready.
Yes.
You are watching it for the next till the patient has a reperfusion. So that's a skilled procedure. So therefore, the message should be very clear that all of us should be trained. All smaller establishments should be trained in giving thrombolysis. Not only in cardiac, also in stroke. They all should be trained. They should negotiate with the pharma companies, get the medicine available on loan with them. And if the patient comes, they talk, they have a tie-up with a bigger hospital, they give them thrombolysis and shift. And they also earn, they also earn. So it is absolutely good for it's a win-win situation. It's good for the patient, it's good for you, and it's good for the center, higher center. They also get time. They also have their family. They also get time. It's 2 o'clock in the night. Every day, cardiologists may not be able to come in a smaller place. In a smaller place where there is only one cardiologist, he will also get, because then you have a window for 24 hours, unless symptomatic. Then you have a window for 24 hours. Up to 24 hours after thrombolysis, you can do the angioplasty. So you can plan. They also have life. So pharmacoinvasive procedure is the procedure as far as India is concerned. It's a win-win situation, everybody wants.
But you have to discuss with the patient
Obviously.
the consequences and the cost factor. Yeah, and the cost factor.
Smaller setup.
Sure.
It will always be more fearful for that.
No, in any way, if the patient can't afford angioplasty, then the situation is different.
Then you keep him there.
Then you give him streptokinase. Take a consent, they give him streptokinase, which is costing less than 3,000 rupees.
Yeah, that's pretty.
So if you are, but the patient can afford, yes, that he should be given. If he can afford a primary angioplasty, he can afford the pharmaco-invasive procedure also with that. And it is very important for all nursing homes, smaller nursing homes, to have a training and to have a tie-up with a bigger hospital.
I think that's most of the people in Delhi at least do. With the cardiac physician, cardiac surgeon.
No, I still find that most of the people in smaller nursing homes are afraid of giving thrombolysis. They should not be. They should be trained. They should be certified. It's a duty of all the interventional cardiologists to train them.
It's only that you must have a defibrillator available if you're doing these kind of.
Anyway, defibrillator.
If you don't have a defibrillator, then don't attempt.
You have to have a defibrillator,
And
whether you have a cardiac setup or not.
Yeah, well, that is always.
You can't run a nursing home without a defibrillator. It has to be there, and you should be trained in that particular thing. AIMS we have a Arogya Nidhi scheme, and a couple of hospitals in the country, as per High Court judgment as well as state decisions, money has been deposited with them. Delhi has around 100 crores.
Sure.
And out of that, say, I think AIMS has been given 1 crore. Approximately 1 crore is lying with AIMS for emergent conditions, because in emergent conditions we have, in cardiology we have acute MI and we have is balloon valve plastic. These two are free. AIMS gives it free, GV Pant gives it free. I think Sabdajang and RML also gives it free.
Okay.
That means if you go to AIMS with an acute MI, they cannot refuse, they cannot say nobody available, and they have to do the primary free of cost there and then. Similarly, in GV Pant hospital, it is free.
Yeah.
Okay. On paper,
Sure.
whether what happens, I don't know, but on paper, it is absolutely free.
Yeah.
But with the rider. The rider is, they will only give you a bare metal stent
Okay.
in an acute MI. And then they say, you go, now you can go for a repair, you can go for a second. They will only look after the culprit vessel, bare metal stent. How good is bare metal stent in acute MI?
See, bare metal stent, there was a time when we were asking this question, how good or is it acceptable to put a drug-eluting stent in acute MI? So, we have now answered that, look, drug-eluting stent is effective and can be used in acute MI. That indirectly shows that bare metal stent is not bad. The problem of bare metal stent is not with acute MI. The problem of bare metal stent is essentially with the size of the stent that you use. If the vessel is more than 2.5 to 3 millimeter, trust me, bare metal stent may even be preferred to drug-eluting stent. So, if the vessel is adequate size, then there is absolutely no qualm in using a bare metal stent, and we do sometimes even today use a bare metal stent.
So, and what I'm trying to say is, if our GP should know
Yeah.
that if they are referring them to a government hospital,
Yes.
where the state provides them a free acute MI stenting,
Bare metal stent.
then there are chances they may be getting a bare metal stent.
Yes.
There is no scheme in AIMS or in GV Pant that if your size is less than 2 millimeter,
Then they'll give a drug-eluting.
Yes.
Yeah.
You will not be given a DES. Therefore, GPs must opt to counsel their people. Person will call up his GP. This is what they are advising. What should I do? So their advice should be to give an option to the hospital that will bear the cost of the drug-eluting stent. Can they put a drug-eluting stent? We have
See, first is that if government, the time to a hospital, suppose time to a government hospital is 15 minutes and time to a private hospital is 2 hours, then I would rather go to a government hospital, get a bare metal stent, come out of that index event with a normal left ventricular function, and I can always keep sorting out whatever the mess is, whether the bare metal stent has got blocked or not blocked, and whatever it may be. In fact, we did that in Gangaram Hospital in cardiogenic shock. Whenever there was a triple vessel disease, the cardiologist doing the angiography will just put the guide wire into the culprit artery to restore the flow, and then send the patient to surgery. And in cardiogenic shock, we could drop the mortality from 46% to 20%. Just that flowing artery. So I think in an acute emergency, if the government hospital is, the first aim is not bare metal or drug-eluting. First aim is within the golden hour, can I get this artery flowing? If someone can put a guide wire and get it flowing, he should be happy and thrilled. We can put any amount of stents later on of whatever category.
Okay, so let me come back to the hypothetical situations, which is a reality actually in most of the situations. Patient can't afford.
Yes.
There will be a lot of people who cannot afford a primary,
More than who can afford.
more than who can afford. And in that situation,
Yeah.
they all come for angiography.
Sure.
They all come for angiography.
Yeah.
And the time the patient says, no, should your procedure be done, that every angiographer should, on humanitarian ground, put in a wire and see whether flow can be
I
done.
wish I was a cardiologist. I'm a cardiac surgeon. At least, I don't know what I would have done, but I think I would have put in a guide wire, get that artery flowing, and then,
Or put it in a bare metal.
well, bare metal if it's in a private sector. And let me tell you, again, I hold an administrative post. Today you say, okay, you have said it in camera, can you tell your cardiologist put bare metal? And anyone who walks in, my answer would be no.
No, I'm not saying that. I'm
Yeah.
talking about a person who is,
Who is ready to afford bare metal?
no, I'm only talking, it's a bare metal. Now stents probably are coming in national list of essential medicines.
Mm-hmm.
Okay. Bare metal is going to be fixed at 18,000, and all other stents will be fixed at 28,000 something. This will be fixed at 18,000, and invariably most of the people would be able to afford 18,000, but not the charges of doing it.
Yeah.
I'm only talking about is that I'm talking about the humanitarian ground, that if you are convinced that the patient cannot afford to save the life of a person, when you're doing an angiography, just put a bare metal, let the patient go, let him pay for the bare metal. I'm not saying that don't pay for the bare metal. Instead of telling the person that go, you can't do anything.
Well, it again,
I don't know how many people,
I know
how many
this-
percentage of such people will be there, but I don't think so it will be more than 5%.
Well, I think the percentage may be 95, but unfortunately the kind of people whom we cater to, let me be honest, we are sitting in the
we are not
poshest of
discussing
posh
NHI.
area.
We are not discussing
No, but
NHI.
even here,
At
so,
the national level.
but at national level, 95% of the people won't be able to afford a bare metal stent.
Okay.
They won't be able to afford a bare metal stent, and it will be very difficult to tell a doctor who is an honorary consultant. He will say, in fact, I'm telling you, 10% free beds that we are supposed to give, for which we have had a fine of 800 crores. Now we struggle. An honorary consultant says, look, the hospital signed that 10% free bed, not as consultants. I'm an honorary consultant. And what law can you use against that consultant?
So you pay them from your own pocket?
Well, if they require, there have been instances when the hospital has paid. Because the consultant says, sorry, I'm not covered by the government rule. Government did not give me land. I'm an honorary consultant. You don't want me to work in your hospital, tell, thank you, here is the handshake.
Looks pretty genuine.
It looks pretty genuine. So there are so many issues. It's a complex thing. It's not as simple as that. You are happy to provide heart surgery, but then if you need an additional support of a nephrologist, where does a nephrologist chip in with his kidney and with his artificial membranes that he has to use in? So those are important things, and the law, I mean, today says that the hospital will pay, but then again, the honorary consultant says, yes, you are paying me. This is not my worry. I want my fees. Whether the patient pay or you pay or the government pay doesn't bother me. And my fees is this. For CGHS patient, they openly tell, this is my fee. If you're ready to accept, please get admitted under my care, otherwise don't get admitted.
Yeah.
They are not ready to accept 161 rupees as the fee. It doesn't cover the cost of the petrol coming and going. So why would he do it? And I'm not blaming them. I'm just I'm narrating the factual situation without
So
raising
many
any
hospitals
fingers.
have refused,
Yes.
bed for them.
Yeah, so this is what they think. So a holistic solution has to be found which is acceptable. That look, today in 2016, how do you expect a highly educated physician being summoned middle of the night at 2 o'clock to come and attend to a patient, and if it is a sick patient, he doesn't come and put his stethoscope for 5 seconds and walk out. He stands with the patient for 2 hours.
Yeah.
And then he goes. Now, how will he work at 161? So these are real, all scenarios that you have quoted are real. The answer is not a mathematical 2 and 2 answer. Every situation has to be viewed, seen in that situation, and upon what bent of mind you are and what bent of mind the patient
In the city
is.
of Delhi, how many cases you might be getting of congenital heart who need surgery and they can't afford?
They can't afford. Well, I would say at least, see, but my numbers that I'm giving you is from my experiences. But my experiences won't be valid because patients themselves do not come to the hospital because they are convinced that the hospital is not going to do us. So why waste money reaching the hospital and then going back? So, but still I get at least once a week or twice a week, a child comes with an unaffordable class who have got a congenital heart disease which calls for surgical intervention.
So what do we do?
Now, we have our own wait list. We put them on the wait list. We are generally doing. We are lucky to have had few very meaningful associations. One is with the Rotary Gift of Life program, where the Rotary International sponsors them partially and we accept them. Then we have a very good association with your very own baby, the Sameer Malik Heart Foundation, where so many young ladies, with valvular heart disease who have been dumped by the family, there we can handle and we are able to do them. So, and a lot of times patients chip in. When they see a patient who has undergone an open heart surgery who belongs to a paying class and he sees a child on the next bed is there, it has happened number of times that the patient's next bed, he says, Doc, I will help this child. They develop a bonding. So if you decide the hospital that we want to help this child, then trust me, never ever has it happened in
So
last 30
as-
years that I have not operated on a poor child because of lack of funds.
So therefore,
But someone will chip in.
So there should not be any waiting list as far as congenital heart disease is concerned. You make your list as 0, and whosoever can't afford, send it to me.
Well, that's a very good thought and a
saying
noble
that-
one, and noble one.
Specifically, the girl child, we have a special attraction.
That's a very
You
noble
know, we
thought,
have
and I
any
appreciate
girl
that.
child if you get, and if she, don't put her on the waiting list. Just send it to us for a formality,
Yeah,
and
that's-
take it for granted that you have full powers to do that, as far as
That's
that is
amazing. I salute you for that. Yeah.
Recently, people are talking about AF, atrial fibrillation.
Atrial fibrillation.
What is the latest in that? I mean, aspirin sometimes, don't give aspirin, sometimes give it, then operative and non-operative. What are the procedures available with that?
See, the main, what shall I say, state treatment in atrial fibrillation still stays medical therapy. Sheerly because of, number one, no certainty with either intervention or radio frequency ablation, surgical ablation. There is no certainty. They have their own failure rates and the cost factors involved, the risks involved. So the mainstay of treatment still stays medical therapy. The debate is between rate control and rhythm control. That debate has not been sorted out. In fact, in most studies, the current accepted view in 2016 is rate and rhythm control have same long-term results. Regarding anticoagulation, yes, we were giving that if the Hasbled score, which we calculate to know the risk of anticoagulation, it is low, and if the patient's CHADS VAS2 score, which we calculate to look at the risk of score, is high, then we should put the patient on formal anticoagulation with either vitamin K antagonists or non-vitamin K, or the newer and dabigatran and those kind of rivaroxaban and apixaban and those kind of anticoagulants. But in elderly patients, we were also using aspirin. Now, the recent data which has come is that aspirin doesn't give you as much stroke prevention benefits as the anticoagulants. So, the newer guidelines mandate that if a person has got long-standing, persistent, or there are three kinds of atrial fibrillation: the paroxysmal, the persistent, and long-standing persistent. So, if it is coming for just a couple of hours, more so like patients with open heart surgery, 30% will get atrial fibrillation. Unless this atrial fibrillation is recurrent, lasting more than 4 weeks, we do not prescribe anticoagulants for them. But if it is more than 4 weeks, then a formal course of anticoagulant, and if that is started, it will be virtually lifelong. And the anticoagulation may not be taken to an INR of 3 or 3.5 as you would do it to a mitral valve. We generally keep it between 2 and 2.5. But aspirin alone for stroke prevention is not enough.
So we have 8 minutes left. Where did you do your MBBS, MD, surgery, other things?
I did my MBBS and my Masters in Surgery from Maulana Azad Medical College.
Joined?
In fact, as junior to Dr. Monga sir, I joined in 72, came out with one long stint in 81, and then from there onwards, being his father was a gunner, so I called myself son of a gun kind of thing. I joined the Indian Army as a surgical specialist, and I did my cardiac surgery from AFMC Pune, from the Military Hospital Cardiothoracic Center. And as the luck would be, not by design but by default, got married to a doctor. She happened to be a assistant professor in Maulana Azad, so sort of merging the two lives was not possible. So I quit the forces, went to Australia and Japan and did about 5 years of training there. Back to National Heart, stint at Gangaram for 5 years, and now back to National Heart.
What is this Almora project?
Almora is something which has been close to my heart because, as I told you, I've been a thoroughbred army man, my father, lots of family members, my own army experience. So all my life has been in cantonments and mountains, and I also love in mountains. And we started going to the mountains of this after return from Australia in 1993 to Ranikhet, and started doing camps with the Kumaon Regimental Center. In fact, we adopted the War Widows dispensary and we used to send medicines from Gangaram Hospital regularly to them by collecting the physician sample for all consultants. I mean, they knew the date that, look, today is the day when someone from cardiac surgery from Dr. Yadav's office will come and collect all your used medicine, and we'll bring those guys and they will send a 3-ton truck with a JCU and carry all the medicine, and we sustained that for 5 years. And from that, my bonding with that area became so much that I started doing more and more camps. And then Jan Khanduri was then the Chief Minister of Uttarakhand, who sort of heard of this and he said, why don't you start with this as a regular thing and make a cardiac center. And we ended up signing a MOU with Government of Uttarakhand, but with the frequent change of Chief Ministers, it did not go forward. And so when we signed the MOU, I precipitated my options and I made my home there. And every month we go there for 4 days, 2 days of camp and 2 days of enjoyment. So I got attached. So now we have restarted that project and we are now in the process of signing an MOU with Government of Uttarakhand once again through the government of Mr. Rawat. And hopefully next week we are supposed to go to Dehradun and sign an MOU to establish a full-fledged tertiary care cardiac center with angioplasty bypass surgery in Almora. And along with that, I have my own NGO called Uttaraina, which we have a small hospital called Uttaraina Hospital, where we give primary and secondary care totally free of cost, but that's a personal effort, limited to 10-bedded small hospital.
Where is it?
That's a 10-bedded.
Where is that?
It is in a place called Paprasali. This is on road from Almora to Binsar, and it's a rural-based hospital. And I invite you, your members of the IMA, to come, given the time of 5 to 6 hours of working in that place, seeing patients, and the balance 2 days they can have in my home, all fun and frolic.
There are doctors there who are running the dispensary in your absence?
No, we have started with a telemedicine program.
Mm.
We have a couple of nurses who have been brought to National Heart and trained, so they give small medicine day to day, and otherwise we have a link up with National Heart Institute, and myself and my wife, in fact, I can openly declare now, my wife has put them in her papers just day before. She's Director Professor of Ophthalmology, and September 20-something she's going to be off, and then she moves in there, and then we hope to provide round-the-clock cover between wife and husband.
Good. That's what that's rare. That's rare that a cardiothoracic surgeon of that stature is thinking of devoting his life to a place like Almora, where with the government the possibility of coming out with a tertiary center, but also the primary center with that. That's all for today. We will come back next week with us, and we will be talking a lot about aspects, the ethical aspects. And if you have any questions, you can send them in advance to us. And I and Dr. Boga, we say goodbye to you, and we thank Dr. O.P. Yadava to be here with us. And we'll come back next week to that. Goodbye.
Thank you.